don't think that more time is needed. You have to have a well-standardized practice with well-performing assistants, and then you do not need more time. I would say that the new methods will not help that we get more patients. I think the most important point is that we get patients into our clinics, and if they are in the clinic, the new devices will help to perform safer procedures with even better results. But we have to conclude that LASIK is at a point where it's very safe and very predictable. Nighttime halos have been very much eliminated with the new excimer laser machines. I hardly hear any problems from my patients, and therefore I think it's not anymore that big issue. Topography can be improved to get better results in patients with smaller eyes, with deep lying eyes. There we still have problems to get good topography, and it would be good if devices would be improved for such problematic eyes. I think if there would be the need, it would have already been the mainstream. We are originally satisfied with our femto LASIK and aberration guided LASIK, which we have had for many years, and therefore I think there is not so much need for this. Of course, this is a big issue, and it's also important to know about the patient, whether he has different illnesses, for example neurodermitis, because there are some illnesses which may also lead to keratoconus or to ectasia after LASIK. It's not only the topography which gives you a hint, but it's also important to know more from the patient and his family. Second touch-up procedures have much reduced during the last 5 years. In our clinic there are hardly any retreatments necessary, and I think this is due to modern laser treatment. If you refer to cross-linking, for example, this will help us to treat patients which we wouldn't have treated years ago. And therefore we might have more numbers of patients with these new biomechanical devices. I wouldn't cut thinner than 100 microns. I know many surgeons do 90 microns, but I want to be on the safer side, and therefore 100 microns is a good cut. I tell the patient that LASIK is a safe procedure, and that I've been doing LASIK now for 22 years, and that I do a lot of other procedures, and this is important for the patient. And I tell him, if you do not want to be treated by me, look for a surgeon who does a lot of surgery, because some side effects may always can happen, but it depends on the skills of the surgeon, what he does in this situation. I tell him there are side effects like over or under correction. There will be halos during the first month, but normally they vanish after some months. And dry eyes, but dry eyes can be treated very well with artificial tear drops, or nowadays with punctum plaques, or with even with the treatment of the meibomian glands. And I think these are the most important side effects, and there are more side effects like, for example, folds in the flap, the so-called striae, but they have become so little or so less with the femtosecond laser. It's very important to talk to the patient and ask him that I will tell him what I'm doing. And if he does not want to know anything, he should tell me right in the beginning. But I tell the patient what I'm doing step by step. And we have always a nurse holding the hand of the patient, and this keeps him calm. And then I ask the patient to fixate the right light from the femtosecond laser. Some patients are very strong in the practice, but if they are in the surgery room, they are really not calm. And this might sometimes be difficult, and therefore I try to ask the patient before in my practice during the examinations, can you stand surgery, can you stand situations with a doctor, and if the patient then says, no, I'm very excited in these situations, I ask our anesthesiologist to help me before surgery. He talks to the patient, and maybe then the patient gets some what we call dormicum, some tranquilizers, in order to go on in surgery. And this really works good. Very important is topography and good refraction. And for surgery, it's a really good laser, a modern laser, not an old laser. This is, in my opinion, very important. And the laser should not be dependent on the climate in the operation theater. No, not at all, because we have eyes from the anatomical situation where I cannot get a suction with a femtosecond laser. And for these cases, I still need a microkeratome. I'm not quite sure, because I have the impression that dry eye is not that theme as it used to be many years ago. I tell the patients before surgery that they might have dry eyes, and I tell them after surgery take eye drops every hour, and then after 2 weeks patient come in and they tell me, I do not need to take them every hour. Is it important to take them every hour? And I say, no, you just take them whenever you have the feeling you need them.